You're listening to the Physio Matters podcast, this month in association with exerciseprescriber.com, and this is session 62. Hello, welcome back to the Physio Matters podcast. My name's Jack March, and this month I was really lucky to be able to interview two ladies with a special interest in hand therapy. I'll let them introduce themselves in the main portion of the podcast, but Sarah Mee and Deb Stanton gave a really good account of themselves discussing all things hands, so we'll get on to that clinical goal in a minute. One thing I want to let you know in this introduction is about Kickstarter. We have a campaign running currently in order to fund a few new projects that we've got moving forwards. We've had a lot of feedback over the years about getting more patients behind the microphones and keeping the podcast to the main feed really to a more clinical subject, and that's what we want to do. But you know, these things take time, they take money, and we have very little of that. So if you don't mind throwing us a few quid across on Kickstarter, it's fairly easy to find. Just go to Kickstarter.com and type in Physio Matters, and our campaign comes straight up. There's a few options for your donations. If you make a pledge of just £1 or £2, then we'll be very, very grateful, and that money will go towards us setting up our projects. There are a couple of levels of pledges where you can receive some really nice bonus content. So if you pledge us £25 plus, then you'll get additional entries into the competitions that you'll have seen us running across social media for free course places. If you go all the way up to £50, then you'll get some webinars plus those competition entries I already mentioned. And if you go up to pledge £100 or more, then we'll give you the webinars, the competition entries, and we'll give you access to all of the videos from the Reforming MSK practice, better known as the Big R's conference from last year. Those lectures were really, really awesome, definitely worth watching. Joe Gibson, Eric Mira, Jaletta Belton, Anina Schmidt, Neil Langridge, the names go on and on and on. And just for £100, we previously sold access for £240, so this is a significant saving. It's only 40% of what it originally cost. You can, by all means, club together with your colleagues or friends to make up the £100, and we'll give you the access to all those videos and the added benefit of really helping us to run these new projects that we're looking forward to. The projects, really, to give you a quick overview, there's 2 extra podcasts that we want to start putting out to go alongside Physio Matters that we all love. We're going to run Patient Matters, where we want to get the patients behind the microphone, hear their stories and hear their journeys to help us become better clinicians moving forwards. And also we want to run Health Matters, where we'll look into the more policy related issues of the time. We've had a lot of feedback where people would prefer the main podcast feed to be a bit more clinical and keep the policy stuff a little bit separate, and that's what we aim to do. So just a reminder, head over to Kickstarter.com, or I'll put a link into the show notes here on the podcast for you to just easily click. Head over there, donate anything that you're able to, and really help us to bring you more and better content in 2019. We'll move on to the podcast here. We're going to talk all things hands and with Debs and Sarah. I hope that you find it useful. I will see you at the other side. Okay, hello everybody. Welcome to session 62 of the Physio Matters podcast. I'm very lucky to be here today with Deb Stanton and Sarah Mee, who are going to take us through lots of clinical gold around hands today. I've just apologised for accidentally saying physiotherapist because Sarah is actually an occupational therapist, and not the first occupational therapist we've had on the show, but the second one. But it's always nice to get different professions in, and we've already had a conversation about the stigma potentially attached to an occupational therapist profession. So hopefully we can dispel some of that today as well. So we're going to talk all about assessment, treatment, differential diagnoses of the hand, and hopefully we'll all be more confident about hands afterwards. So first thing I'm going to do is ask Debs, do you want to introduce yourself a little bit for our listeners and tell us what you've been up to with your career to date at the moment?
Thank you. My name is Deb Stanton. I'm historically a physiotherapist, but I do call myself a hand therapist. I trained at St Thomas's a very, very, very long time ago. Then worked at King's and then ended up at St Thomas's running the outpatient department there, where I fell into hand therapy after one hand therapist got sick and one had a baby and there was no cover. And well, that's the history of how I started, and I've been a hand therapist ever since. And I now currently work in Colchester for an AQP.
Perfect. And Sarah?
So I'm an occupational therapist, as we said. I also trained in the late 80s and did 3 years of general OT rotation before I did a rotation as a band 6, it would be, in burns and hands. It wasn't anything that I knew much about. We hadn't really done it as part of our training, but it suited me perfectly as a combination of sort of OT and physio skills, I guess. And I've been a hand therapist ever since. So I did burns for maybe 5 or 6 years, and then I've specialised in hands since then. I do a lot of teaching, so I've done national and international teaching for probably the last 20 years, and that's the sort of second half of what I do. So I'm now a consultant hand therapist working at Chelsea and Westminster Hospital in London, and running a team of 16 hand therapists, half OT, half physio, but all with generic skills. And I'm a partner also in NES hand therapy training, which does a lot of training around the country. And I'm accredited hand therapist BART, which has been a British Association of Hand Therapists accreditation to say that you've reached a certain level of gaining generic physio and OT combined skills.
Brilliant. So we're going to refer to everybody as hand therapists today rather than any specific professions. We're going to leave professions at the door for the day. The first question I sort of wanted to get into really with regarding hands is, do you think there's a bit of a stigma attached to hands with them being difficult? I certainly remember when I was a student, there was this story that went round that on our first placement, someone was in outpatients and their first patient they ever saw was a hand, and everybody sort of did a collective sigh that might be the hardest thing ever. Are they particularly difficult hands, or are they just sort of the feet of the arm?
We're both looking shocked.
Yeah, generally not walking on my hands that much.
I think they are quite complex. I think the anatomy is quite similar to the foot, but what we're able to do is different. And I think what we need to achieve with our hands makes therapy, recovery from injury or recovery from acquired conditions quite difficult. I think there's a combination of using our hands for socialising, for speaking, as well as for fine dexterity, heavy work, weight bearing. It incorporates almost everything we do in function, and I think that makes it complex.
I think also what makes it complex is that there's no space in your hand for anything to go wrong. So if you have a small amount of swelling around a tendon in your hamstring or biceps, it doesn't really impact on any of the other structures around it particularly, but you only need a very small amount of swelling on a tendon in a hand for it to impact lots of the other structures, and to create pain, disability, difficulty. So I think just the actual physical anatomy of the hand does make it more complex and more difficult to deal with, and you do require a really detailed knowledge of your anatomy to be able to treat those things well and work out exactly what is and isn't going on.
Yeah, I mean, we talked slightly before we started recording about sort of hand therapists almost being a separate department. And would you say that that's a necessity for the hand? Do you think there's a role for the generalist musculoskeletal therapist to treat some sort of conditions, and then other conditions need really to be under hand therapy?
Yeah, I think that's right. I think a lot probably do need to be under hand therapy. I think you need a combination of OT and physio skills, as we said. I think you need to be able to do detailed assessment. You need to have some splinting skills. I think that you can use off-the-shelf splinting, but a lot of the time, because the shape of the hand is complex, it's hard to find splints off the shelf that fit. And a badly fitting splint is more of a problem really than not wearing one at all. And I think you need to understand the sensory side, the functional side, the physical side. So I think a combination of both OT and physio skills is necessary to treat a hand well.
Yeah, I agree completely. And I think that with the neurological entrapment type syndromes that we do see a lot of in hand therapy, you really do need to be a hand therapist. You can't treat them without having OT skills as well as physio skills, particularly. You need to be able to splint. You need to be able to manage those in a way that most physios can't manage. And you need to have a good understanding of retraining of things like stereognosis, which unless you are a hand therapist, you probably haven't ever come across or dealt with.
And I think certainly as an OT, the things I've had to learn very much have been the musculoskeletal side of things. So I don't think you can be just an OT either. I think you need to know about the upper limb. I think it's easy to try and separate the hand from the upper limb, and you can't. You need to be able to deal with it bilaterally. So I think as an OT, you have to learn all of the musculoskeletal side of things as well, and understand the muscles and how all of that works. So I think you need the combination, and that takes years to build up that knowledge to be able to treat a hand well enough.
And to have enough insight to know when actually it needs to go back to a physiotherapist that is particularly specialist, more maybe in cervical spine or shoulder.
Yeah, there's a lot of complicating factors, isn't there? When you get that hand, it's not just a hand, is it? It's attached to a human being. So we'll move on to talk a bit clinically now. So what would you say the sort of the most common conditions we're going to see in a musculoskeletal department? Where would you, if someone turns up with we've all seen those referrals where it says hand pain or something. What would you say the most likely causes of hand pain are going to be in our musculoskeletal department?
I think it's, I'd thought about a list of things, and I guess it is that group that go through MSK primary care first, and it's, CMCJ, osteoarthritis, de Quervain's, or along with de Quervain's is tenosynovitis, lateral epicondylitis. Now, whether you put that as hands or arm, again, is one of those in between. Sorry, I am. I'm heading to the elbow. I'm sorry about that.
Careful.
We see a lot of trigger fingers, trigger thumbs, carpal tunnel syndrome, ganglions, and then I guess the other big area is work-related upper limb disorder, where the symptoms are often in the hand, but actually the problem is very upper limb, trunk posture. Those are the things I would see most.
And ulnar-sided wrist pain is the only other thing I'd add on to that. This sort of rather nebulous, strange ulnar-sided wrist pain that can be difficult to kind of pinpoint and pin down. But I don't think there's anything else that I would see really commonly that you haven't mentioned. No, I think that's probably it. So that's all the atraumatic stuff you're talking about, not all the other common trauma,
falling down stuff. Yeah, we'll leave those for another podcast. I think. Go
Yeah. I think the only thing to say about that though is that the stuff that comes to me post, say, collis fracture, there is a big cohort of that comes to hand therapy. So the ones that end up with a lot of hand pain post an injury like that will come.
And I guess as well as the distal radius injuries is then PIP joint injuries. So there's another big group of soft tissue injury, small fractures, dislocations of PIP joints, that end up being stiff with fixed flexion deformities, etc. So it's that group that come maybe a bit later when they're struggling.
And they often do come through the GP because often patients ignore them, or the coach has decided they're going to pull the finger back into place and told them it'll be fine.
Yeah.
And
I knew
so
there was a reason we wouldn't talk about trauma. The heebie-jeebies,
But that's that those do come through the normal sort of MSK pathway rather than through the orthopaedic fracture clinic pathway frequently.
Yeah. So it sounds like it would be a combination of sort of the systemic stuff like osteoarthritis and then rheumatoid potentially, and then sort of a lot of overload type syndromes as well.
Yeah.
Like you said, with sort of lateral epicondylitis and tenosynovitis or
entrapment neuropathies.
Yeah. That was my next question. Sort of the sort of things that would come through that would be more of a masquerading type diagnosis. What would you say what things that we really should be looking out for? We can talk about these a little bit more later in depth, but what would be the main sort of conditions that might masquerade into the hand?
Well, I suppose your things that are referred as something like a carpal tunnel syndrome. Obviously, all good hand therapists will make sure that they looked at the neck, but a lot of that comes from history. Often referrals will come through carpal tunnel syndrome, and often they are carpal tunnel syndrome, but often they're not. Radial tunnel syndromes, I suppose. Yeah.
And cubital tunnel syndrome. I think it's, there are a lot of cervical radiculopathies, a lot of postural work-related stuff manifests in the hand. Diabetic neuropathies, things that produce tingling, pain, feelings of swelling, feeling of discomfort in the hand, often relates to more proximal problems, or may have a bit of that as well. So there may be a bit of irritation of a median nerve in relation to a carpal tunnel syndrome, but it may well not be the whole picture.
And all the metabolic stuff that goes with that as well.
So I think that's where, again, it's good to have combination skills, because I think you do need, if you're going to manage the hand, you do need to understand the limb, the whole of the limb. You need to understand the upper quadrant, sufficiently, or at least know that you have to refer them on.
Yeah, we talked about, before we came on recording, we talked about sort of holistic assessments and holistic care as well. So obviously you're going to be looking at sort of the general health of people, as well as, and like you said, with work-related upper limb, sort of their stress-related responses from work and those kind of things. Do you find, it's difficult to say with whether that's more prevalent within the hand, but obviously it's an issue that needs assessing. Would you say it's more prevalent in the hand, that sort of things that are not necessarily overload related purely to the hand? Would that be more common there than maybe other areas like the shoulder, for example?
I think it probably is. I think that obviously stress related and work related upper limb disorders can give symptoms anywhere in the arm, but I think ultimately nearly all of them develop hand pain at some point, or all sorts of pins and needles, swelling, skin changes, weakness. I think they probably do, actually.
Yeah, and I think it's, we see quite a lot of people with hypermobility underlying, so they may have some proximal core instability, but again it manifests in the hand. So a huge number of people that I see coming through my triage clinics come with hand pain, but a reasonable proportion of those actually don't have anything mechanical going on in the hand or forearm. The problem is postural or more proximal. It may be that they have trigger points in the forearm muscles that are exacerbating the issue. But I think, it manifests in the hand even if the problem is a bit more proximally based.
So do you think we should move away from the term repetitive strain injury? Is that...
I think it's very hard. It's going to be one of these terms like complex regional pain syndrome that I think there's going to be a constant move of changing. Work-related upper limb disorder has been the newest way of discussing it, and I think that probably incorporates things in a different way, but a lot of the overuse problems that we see don't necessarily relate only to work. If you're at a computer all day, that may be part of the problem, but you're then going to sit on the train with your phone all day, or going home you're then going to sit on your sofa in a scrunched up position on your laptop. Actually, a lot of the pain and problems doesn't come only from work. It comes from how we lead our lives. So I'm not sure that work related upper limb, I think repetitive strain, I'm not sure it matters hugely. I think they're all a global term, and our job is to try and work out why it's happening.
Text thumb.
Yeah, well, we're seeing. I mean, we're definitely. I mean, technology has changed things. I've been doing hands for 30 years. We're seeing a whole different group of people much younger as well who are coming with pain and problems, particularly in thumbs, relating to phones and relating to iPads,
and relating to the devices that look like phones but that are used in shops for stock taking,
Oh, right.
in which they have to scan, and it is highly repetitive, and it's that same position, and those same people obviously are using their phones as well. And we've developed a cohort of patients that is quite significant with those.
Yeah, no, exactly, and I think it's an area that we all have to be very careful that we don't just treat the mechanical signs either upper quadrant wise or more distal, more peripheral, and that we don't spend enough time looking at the environment, looking at the stresses, looking at the other aspects. So what's their posture? We were just talking earlier about refresh exercises. We've become very static in the way that we do things. And a lot of the problems in the upper limb relate actually just to changing position. You can be in any position you like, so long as you change it often enough. And I think that the feeling that you have to have a set way of sitting at your computer with a set keyboard, actually it's far less about the equipment we use, and it's much more about how much we move and how much we change our position through the day. So I think there's a big part of both MSK physio, but also from a hand therapy perspective, where we need to be looking at that global, how do we live our lives, and how does our posture and our, upper limb position relate to pain we have.
It's no different. I'm just thinking about. There's no difference really between neck, sort of our non-specific, if I use inverted commas, neck pain, low back pain, because sort of telephone use, for example, is endemic, isn't it, in society? So we've obviously got some people that will develop these hand-related problems, and other people that don't. And I saw a thing on social media about people. It was about the neck, but we can relate it to the hand. There were all the people sitting on a bench reading their newspapers, like flexed forwards. Things we haven't stopped using. We might use our hands slightly differently now, but I don't know. Do you think we use our hands more now because of technology, or do you think it's more that static and general health changes? Maybe?
I think we use our hands in a different way rather than more. I mean, we've always had to use our hands to achieve whatever task we're trying to achieve, but I think that the way we are using our hands and what we are using to achieve that has changed hugely, and I think that is having an effect on what we see.
Yeah, and I think particularly for things, if we think about the thumb, that we know the most stable position for the thumb is in a degree of abduction. We know that the best position to maintain all the thenar muscles in a good position to maintain their core stability is to be using our thumbs in an abducted position, so coming around to the tips of the fingers, more in a tripod type grip, is by far the best way of managing. Now, phones and technology, you use it in an adducted position, and that means that you lose stability in your thenar muscles. A lot of what we're doing as hand therapists is looking at the type of grip. So actually looking at what's the difference between a pure pinch, a tripod, a 5-finger pinch. The actual differences in grip will make a huge difference to just the stability of those muscles. And I think what happens for a lot of people is we use them in the least efficient way. We lose them in a position that puts the CMC joint under strain, and we certainly see a lot more CMC joint pain because the core stability of those thenar muscles is not maintained, and that relates to the postures we hold our hands in for things like phones. So I think, again, as a hand therapist, you need to be able, or certainly as anyone treating a hand, you need to look a lot at type of grip and potentially grip retraining, so that people can still use a phone but use it in a different way.
Interesting. Okay, brilliant. Okay, so if we'll move on to talking about our assessments of hands. So we'll go back to my referral that we've all seen. Where you get this referral and it's hand pain, and you go, well, that could be a million different things. So you've got your person sitting in front of you, and you sort of where would you sort of start with a subjective assessment? What kind of things do you start to begin to cover straight off the bat?
Well, I think, with no different from any other assessment, you want to hear from whoever's sitting in front of you, their journey. You want to hear what they think the problem is, and you want to be able to hear and just let them tell that story. Even if at the beginning it doesn't really seem to make any sense or doesn't seem to be relating to what's going on with their hand. And then you can only then can you move on to a little bit more specific.
Yeah. And
obviously with the hand, you particularly want to know, dominance, occupation, very important. Occupation is important with all therapy assessment, but I think with the hand therapy particularly, and also exactly what they do during that. So if you have, I live, as I said, in Colchester, and we have Tiptree Jam nearby. People often say I work at the jam factory, but when you work at the jam factory, there's a whole load of different jobs that you can do there. You want to know exactly what they're doing all day, every day, and then obviously move on to sports and hobbies, and particularly ones that are they into doing craft. I mean, how many people do we have that are very into using craft, needlework, instruments? Do they play an instrument? So just moving slightly towards finding out specifically what they're using their hand for. I think that's where I would always start. So that would take the best part of my assessment, just trying to find out exactly where they've come from, and how things have developed over time, how that might relate to their occupation and their social history.
Yeah, and I think within all of that, the sort of background to that, and the thing you keep coming back to is their pain and their symptoms. I think it's quite hard often for people they come with hand pain, but we need to know, is that mechanical, is it neural? So a lot of the time they may read pain as tingling or pins and needles, rather than a mechanical type pain. So I think within all of the function is the normal questions about pain of aggravating and easing factors. But I think being very specific in the difference between neurological and mechanical type pain, because that can definitely help to lead you, and it may be that they have both, but that may well help you to be looking more at whether it's a more local peripheral problem or whether it's a more proximal problem as well, and getting more of their idea as to how it relates to function. It's coming back always to grip and function.
Yeah. Are there any sort of triggers that patients will tell in their stories that might immediately lead you down a route to help you differentiate between either neural or inflammatory or mechanical? Is there anything that they that flag up immediately, sort of in their story, as you said, Deb?
Well, I think the normal ones that for the more systemic diseases that you would be looking out for, early morning stiffness. It occurs in the hands in the same way as it does anywhere else. So if patients are saying that their hands are really stiff in the morning, take a long time to get going, they're filling the sink up with warm water and finding that they've come in and they've already started trying to use a sponge or something to try and loosen up their hands in the morning. So of course that will make you think, is there something maybe a little more systemic going on here? I think obviously night pain. We want to make sure that we're excluding anything that could be that might need further investigation. I think possibly the more insidious type onset of symptoms that have started very quietly and have just grown and grown, and rather than those that have come on with a bang, as it were. I think if you've got something that's really inflammatory, often it comes on very, very fast, very heavy. They associate it with very specific activities. They know that if they rest it or ice it, it tends to go away, whereas there are those other things that they just can't seem to make it get any better, they can't seem to make it get any worse. They might describe a way that they can kind of offload their arm. They might say, well, actually, if I sleep with my hand folded across my chest, it feels a bit better. So obviously Sarah mentioned the actual symptoms like pins and needles, etc. But take that as read that people will follow that up as neurological rather than anything else. But
yeah, and I think the only other thing perhaps is just the type of pain. I think with neurological issues, they will often describe it as burning. And I think that is a specific word almost that we're looking for. It's not, it obviously can relate to a variety of things, but I think that's one of the ways that leads you a bit more down the neural side of things. But we often, it may well be something that's been around for quite a long time. And so by then, they also have symptoms relating to disuse, general weakness. So, you can end up with quite a complex picture of pain. But I would agree with everything Deb said, yeah.
Getting into my comfort zone talking about inflammatory conditions.
Absolutely.
So let's say you've got sort of a they've got some burning pain. You're thinking it's neural potentially. Where would you start to go with your subjective assessment to pick out those patients? You said about it could be a cervical radiculopathy or an entrapment syndrome at the elbow. Is there anything you can get from the subjective that can lead you a little bit more down that route to help you?
I think some is about location, so you can potentially get some maybe from the history, some maybe from the onset, and patients' description of radiating pain, where the pain moves to, is it only ever localized, and I think their description of where it relates in the hand. So does it relate to a particular nerve? Is it more global than that? If you're looking for carpal tunnel syndrome, it can only relate to the median nerve. So you're looking for a certain innervation. So some of that description of location makes a change.
And I suppose also whether it's associated with weakness, because, in terms of your anatomy, some nerves will give you weakness and no change in sensation, and some nerves will give you change in sensation and no weakness.
Yeah.
So just kind of really drilling down to the exactly where they think it might be coming from and going to. Because patients give you quite a lot of detail.
Yeah, they do.
If you ask the right questions, they'll point you in the right direction. But these things are complex, and sometimes it's both. You can have carpal tunnel syndrome and a bit of a radiculopathy as well.
Yeah.
Dare I say it?
and it may be that you just don't. You don't find you can't work it out straight away.
Yeah.
As well, sometimes you just have to. I think a lot of this, it's nice to think that we can diagnose in a first session, but you often have to start treating the symptoms that you see, and you may well end up with getting a clearer idea as we go through. And I think also what brings it on is one of the biggest things is what makes it worse. What are the situations, what are they doing at the time, what's their posture at the time, is it sustained, that sort of coming back again to the history of what aggravates it may well be a way that helps you to differentially diagnose. Yeah.
Is there much in the way you said, Debs, about holding the sort of a hand across the chest? Is there much about how people position their arms for relief that can help?
Well, the carpal tunnels, they all say the same thing. They wake up in the night, hang their hand over the edge of the bed.
Exactly, and
or
shake
it out and shake it out.
And I think people that have an ulnar nerve issue have a cubital tunnel. The problem with the elbow, bending the elbow is worse. So the most common thing with that is things like holding their phone. So having the elbow bent for a sustained period of time, leaning the elbow on the table. So there are certain nerves that we know become compressed in certain positions. And so they may well be describing those sustained positions reproduce their pain.
I'm having to text with my other hand.
Yes, exactly.
My elbow's bent.
I can't avoid texting.
No, absolutely. Or scrolling.
Yeah,
scrolling through my feed. That's not a good thing.
Yeah.
I don't think generally.
And does it tend to come out in the thumb, like with these? Let's take phones for example. Would you say it tends to come out in the thumb, those symptoms, rather than the fingers? Because I think about how I use a phone, and the stress to me feels like it's through the fingers, if that makes sense. But
it's the habitual position that the thumb is in. That's I perceive. I don't know if there's any research, so I'm actually just talking about my own clinical experience. It's the habitual position of the thumb that I perceive to be the issue. I think in terms of carpal tunnel, yes, if people are holding their wrist bent for really long periods, and there are people that hold their wrist bent, they will spend hours and hours and hours and hours over the day and over the week with their wrist bent, and their their thumb in a sort of adductive position, just continually adducting, and so they'll get pain around the thumb and possibly pain related to that median nerve that comes through there as well. But it will always tend to be on that radial side of the hand if it's a phone related type thing. I don't think I've seen many phone related type injuries are on the side, except, as you say, cubital
been in the
tunnel.
elbow, and I think some phones are quite a lot bigger now. So people are also carrying a weightier phone, and so we see a bit of irritation maybe in the hypothena. But that really is just if you're holding the phone in there. It's much more about the thumb position, and it is about that CMC joint sitting in a very adducted position. We know that's a position of instability, and the more time people spend there, the more problem we have. But some of it relates really very much to the individual neural compression that we see.
And just before we move away from it, you said, Debs, about night pain, and you were hinting at red flag type conditions. Are there any particular, for the hand, is there any particular sort of red flag type conditions that might present in the hand specifically, or that we should keep an eye out for?
Well, I suppose in the hand, the hands are quite lucky. Most lumps and bumps in the hand are benign. Obviously, you do get tumours in the hand, but I can't remember the exact figure. It's only about 5 or 6% of lumps and bumps in the hand turn out to be anything nasty. But I just think more systemically, red flags in terms of rheumatoid disease and other inflammatory arthropathies. And I think if people have got kind of generalised weakness in the hand and you're not sure and it looks like it might be some kind of polyneuropathy, you've got to be thinking more about your metabolic conditions. We do see lots of lumps and bumps in the hands. In the hand, they're very common, and they are something that present to us, lumps and bumps. And they do cause pain, and actually they often cause problems as well, because there's no space in the hand for benign lumps and bumps. Whereas in other bits of the body you can have a nice lipoma and it doesn't really make much difference, but if you have a lipoma anywhere near your Guillen's canal, then
and even quite small ganglions will cause quite a lot of issues. But I think it's being aware of other neurological issues. You can get sometimes unusual presentations of MS, things, much more systemic neurological problems that start in the hand, can start unilaterally. And occasionally, problems in cervical spine or upper quadrant, with tumours at that level. But they're relatively rare, unfortunately.
Brilliant. Okay, so we've taken a lovely history from our patients and we sort of move on to objective, and this is where I really start to think, this is where my skills start to fall down, objective assessments of the hand. And I think there's so many joints and so much movement and so much complexity in the hand. Do you want to give us a brief, let's go with you, Sarah, do you want to give us a brief sort of what things are you looking for in the hand objectively initially?
I think you need to be quite systematic. There are a lot of structures. I think you, as always, start away from the pain. So don't go for the area that is going to produce the most irritation straight away. Try and exclude, if you can. Once you get around the wrist, it becomes even more complex with a number of structures and things that relate around that. But I think, again, you want to look at active range of motion. So start just with the basic, what can they do? Do you notice a change in their range of motion? Does it bring on their pain? You can then do some passive range of motion. You can do some joint compression, joint traction, accessory mobs to have a specific look if you think it might be intra-articular related. You're going to want to palpate soft tissue-wise, just to have a look and see, again, relating to where they say their pain is. Is it relating to muscle in the forearm, muscle in the hand? And then potentially specific provocative testing. So you may want to be looking at neural tests. You may look for a Tunnel sign to see whether there's an irritation in a particular nerve. If you tap along it, you may want to look for trigger points in muscles. So I think the palpation is going to relate very much to where you're headed with it. There are a lot of very specific provocative tests around the wrist in relation to scaphoid shift test, specifics looking at carpal ligaments, and again tests for CMC joint, things like the grind test, again relating very much to building up your test in the same way you would for any area or joint. But being very systematic at working through the different anatomical certainly in my mind, I have in every area I have a list of anatomy that sits in that area. So I tend to look at it from a radial dorsal area, across to central dorsal, ulnar dorsal, volar, ulnar, etc., and working through almost zones of the hand in order to make sure that I'm not missing anything as I go through.
We do quite a lot of testing as well, don't we? Recording, testing, strength. So with a JMAR dynamometer, pinch, and making sure we record. What we briefly touched on before, type of grip and type of pinch. So you might record pinch in a key grip and pinch in a tripod. And goniometry as well. We use quite a lot of goniometry when people come in with very specific restrictions in range. But you have to have the right kind of goniometer. Okay, you need a little tiny one, and you need one which has got lots and lots and lots of little marks on, so that some of the older ones where the degrees are every 5 degrees, and the arms are too long, so you can't quite get it down past the wrist. So kit is quite important. Yeah. If you want to have a detailed assessment that obviously can be picked up by anybody else in the department, and they can make a good judgment onto whether what you've done previously is making any difference or not. And in the hand, obviously, in terms of objective, we do some specific functional tests sometimes. We might do something that's really simple and easy to have in the department, like a 9-hole peg test, which is a timed dexterity test. It's a tiny bit of kit, fits in a drawer, it's quick and easy to use, it's not complex, you don't have to fill in lots of forms, so it's quite a good one in a really busy clinic just to have.
And I think the other aspects that we haven't really talked about, sensation. I think if you find there's a neurological problem, it's actually very important to assess sensation properly. It's easy just to do a can you feel this or not. But actually I think if you're doing any sort of handwork, you need to look particularly at
That's the coffee machine going
exactly.
off in the background.
We'll just stop briefly while the coffee machine's going on. I think it's very useful to have a basic monofilament test. I think you have to be able to assess your sensation in a standardized way. A lot of patients that have neurological problems, it's very different if you have a neurological injury to if you have a compression. And I think it's very hard to rely on a patient's subjective view on how their sensation is improving or worsening. So I think monofilaments is going to be it's a threshold test. It's the most standardized way of doing it. It's an expensive piece of kit to buy in the first place. But again, it's a quick and easy way of doing it. It's very responsive over time. Gives you a very good feel for that. And I think with function, everything we do with the hand in the end relates to function. So using patient self-reported questionnaires, we tend to use a dash or a quick dash for a lot of patients. We use a PSFS, again, same as MSK, just to get a view from the patients on subjectively how is their function, and then coming into something more specific like a grip ability test, something where you can actually measure the type of grip that they use. So I think it's prioritising those, because that could take you 5 hours to achieve. So from your basic assessment initially is then looking at, okay, what standardised testing do I need to do? But the hand is so complex that I think you have to assess carefully and in a prioritised way. So it's not just the subjective view. I think you need to get...
Yeah, certainly a specific thing I had about thinking about the hand was, like you said, equipment. Often we don't have this kind of equipment. And we were talking about when we were preparing the questions and things for this podcast, and often the way that I'll test strength of the hand is just to get them to grip 2 of my fingers and just make an assessment as to whether I think, in my head, is that a roughly right amount of grip? And, I know that that's not the right way of doing it, because people will vary so significantly. How do you feel like you need to be very specific with a lot of your tests with the hand, maybe more so than you would need to be with the shoulder? We might rate shoulder strength out of 5, for example, 3, 4, 5, whatever. Do you feel like in the hand you need to be more specific due to its complexity, or do you think I can get away with going, yeah, that's about right?
Probably not.
Probably not.
No.
Yeah, I would say that in the hand it's almost essential to have a good record of exact strength in grip and in pinch, particularly if we're talking about neurological.
Yeah, and I think if you look at all the research everything's done, if you look at the amount of research out there on measuring function, measuring grip strength, looking at patient satisfaction and everything else, you really don't get it unless you assess well enough. And I think the problem is, we know even with something like manual muscle testing, it's not very objective. A grade 3 is the most objective we can be, but you're not going to remember it, that is subjective on our part. A lot of sensory testing is quite subjective, but I think in order for us to know that there's a huge range of treatments that we can do, is what we're doing being effective? A lot of the time with hand problems, patients don't end up being exactly the same as they were before. And it's very important to have a way of saying, well, look, this has been your improvement over time. So I think it is complex enough. And I think it's complex enough that you need a range of testing. I think we have to be very careful that you don't just end up testing the easy physical things like a range of motion. Because actually you can have a stiff hand with good sensation that's extremely functional. You can have a hand that moves completely normally with poor sensation or numbness or tingling, and that will have a much bigger impact on any function ongoing. And I think sensation and functional grips are often forgotten about. And I think that's a real problem. I think you need to assess them well in order to treat a hand well.
And I suppose you have to relate those readings to, as you said, the patient's function. Like, if I go to my comfort zone of rheumatology, I've seen some horribly deformed hands that actually people can do pretty much whatever they want with. And then you see someone with, inverted commas, a little bit of CMCOA and they can do hardly anything. So, I think, like you said, I think that needs relating to their function. Do you go, if you've got an unlimited length of assessment, would you go proximally to the hand as well to test the strength into the elbow, the shoulder?
Yes, I mean, I think if you, and I think you need, in your initial assessment, if there's any evidence that more proximal problems are related, then yes, I think you do. I think anyone that has underlying hypermobility, so if you're checking a Baton scale and looking at hypermobility, I think that would absolutely mean that you need to look proximally at trunk stability and shoulder stability, because a lot of hand problems in function with hypermobility relate to proximal stability. So I think, yes, I think your initial assessment will lead you. I think you've always got to keep that in the back of your mind to manage proximally. But I think it needs to be alongside. Yeah.
I mean, I would say that I wouldn't probably go proximally if it was really specific, something like a first CMCOA, but more the kind of the insidious things where they're not quite 100% sure exactly where the problem's going to be coming from. I'll always have a quick look at, I won't do everything, but, wrist flexion extension, pronation, supination, elbow flexion extension, shoulder, just have a quick look at, abduction. Probably the only one in this. I think the shoulder is, but in terms of strength, if I've done, elbow flexion extension as well. And then pretty much always, if it's something that seems neurological, just look at neck range of motion as well.
Yeah, okay, brilliant. And we talked about neurological quite a bit, and you obviously we mentioned sensation, etc. What about the sort of more specific tests, neurological tests, Hoffman's sign, those kind of things? We mentioned Tinnell's already. Are there any other anything specific around that you would always complete, or is it on a specific person by person basis?
Person by person. I mean, you wouldn't do a Phelan's on anyone with hand pain, but you would on anyone you suspect to have a carpal tunnel.
I think often the a Tinnell sign's quite a useful way just of giving you an idea as you're just tapping along the nerve, going distal to proximal, and you're really just looking to see, does it produce an irritation, so does it send that sort of radiating electric shock pain distally? And I think that can give you just a reasonable view of, is the nerve irritated, at Guillaume's canal, for the ulnar nerve, is it related, at cubital tunnel, is it related sort of higher up? Phelan's, you need, again, to do it, there are any number of ways that people do Phelan's. So I think if you're going to do any of them and you're going to document it, you need to make sure you're doing it in the right way. But, with all of them, if you look at the evidence, there's really no more than about 60% sensitivity or specificity on any of these provocative tests. So they may be useful to sort of help to put the jigsaw puzzle together, but none of them are going to be as clear. And, and I guess while we're on that is nerve conduction study, looking at neurophysiology, that it can be helpful as an adjunct. We know they're false positives that come from nerve conduction studies and the latest information from the BSSH and on the Cochrane is that nerve conduction studies are not necessary, they're not mandatory for peripheral nerve problems if they follow a classic picture of carpal tunnel syndrome. So actually the first port of call for things like cubital tunnel and carpal tunnel syndrome is a clinical assessment. So a history, common history pointers and a clinical assessment, and nerve conduction studies only if you're concerned that there may be other aspects to the nerve that are not fitting the picture.
So would you consider the nerve conduction studies now confirmatory rather than diagnostic, almost?
I think yes. I think if we're looking at carpal tunnel syndrome, if there's a very clear history that fits, a clear clinical picture, nothing else happening more proximally, it's certainly reasonable to start treatment. And that's now what the NICE guidelines and everyone is saying, is that don't rush into testing at this one because of the false positives. There are a lot of people that I think have been over-treated in those early situations that actually could be managed with a clinical assessment.
Okay. What about things like swelling, redness? Dare I mention nail beds?
Yes, you can mention nail beds. Yes. Well, nail beds are the one area you do have to be careful of in terms of red flags. But yes, obviously, as part of your objective assessment, I think before you go asking people to move or moving people, obviously you want to have a look at the hand, have a look and see whether there is any general swelling, whether there's swelling around any specific joints, if there's swelling specifically in terms of lumps and bumps, and whether there's any area of skin change, redness, but also mottled areas in the hand. Obviously, in your subjective, you hope that you've managed to bring out if anybody's got any problems with circulation, specific circulation in the hand. And right now, my brain has stopped working. What's it called when they go white? Raynaud's phenomenon.
Yes.
Okay, so obviously we want to make sure that we have excluded things like Raynaud's, or we know that people have Raynaud's, and obviously there are some rheumatological conditions where circulatory changes in the hand are more common than others. But also on your subjective, you will know whether your patient has been a diabetic for a long time, if they take some of the older anti-epileptic medications, which can affect circulation. Obviously we will look at that. But I don't think specifically if there's any particular thing you're looking at, unless you're thinking about CRPS, when obviously you're looking at skin changes then, but there isn't a particular skin change you're looking for then. You're just looking to see whether it's different from the other side, because people present with pale hands, people present with red hands, people present with mottled hands, sweaty hands, dry hands, fast-growing nails, not fast-growing nails, shiny and hairy, shiny and hairless. There isn't really a specific pattern, but it's different to the other side, because luckily people generally have two hands. And more often than not, it's only one hand that they come with, but obviously with a lot of the arthropathies, both hands are affected, and sometimes symmetrically, so you haven't really got a same to compare with on the other side.
Yeah. I think when I do my teaching on rheumatology, people definitely aren't aware of nails. As a general rule, that's what I sort of notice. People are surprised when I bring up pictures of nails, that that can present as a change.
Well, I mean, you'd hope that in your subjective, if you've got something that, if you've been referred to hand pain or generalised small joint pain, that you have asked about things like psoriasis. Obviously, sometimes people don't know they have psoriasis, which is one of the things that we have to be aware of, and you're looking at nails for that. In terms of red flags around nails, it's really discoloration in the nail is something that you should never ignore, and also really, really acutely tender, really acutely tender nail beds can be reflective of something that needs further investigation. So,
but an awful lot of hand conditions don't relate or don't have nail problems. So I think it's one of those things again that you need to be aware. It should be in your checklist. But it's relatively rare, and I guess that's why it gets forgotten. It's always one of those things that we need to be sure that there is a quick check of it to make sure. And I think any other inflammatory, things are just as they would be with any other joints. Looking for heat, looking for how long they've been around. Trying to look at acute inflammation as opposed to chronic, and some of the differences between septic arthritis, other arthropathies, gout. Those which can't always be seen clinically and may need ultrasound assessment. I have a fairly low threshold for sending people for an ultrasound assessment just to look at underlying tissue. So I'm lucky in that I can, if I have to, I can get one done that day. I can certainly get one done within the next 2 weeks if I'm worried about anything. There's a much longer wait for a non-urgent. But you often need just to get that bit of imaging in order to confirm what you're seeing as well.
Yeah. And what about, we've mentioned a lot of lumps and bumps, and things like ganglions and Heberden node. I don't know how you say I always want to say Heberden. I think that's probably my accent. But the different nodules that you can get in the hand, or gout tophi. I mean, do you know how much stock do you put into those lumps? We see a lot of people with changes in the hands and things. How much stock would you put into that for each person, do you think?
Well, if you're talking ganglions, then we don't really worry about ganglions. There are some ganglions that cause problems, and they're often the ganglions actually that you can't see very well. Right. The more occult, scapholunate occult ganglions, which can cause a few problems. I mean, I think the one lump that you may think is a ganglion that you have to be aware of is giant cell tumours in the hand. So giant cell tumours in the hand, probably most common in the thumb, would you say so?
Yeah, I would think so.
And they can feel and look a bit like a ganglion. If you're not used to looking at hands and ganglions, I mean, if it's really prominent and easy to see, actually you can do something simple like shine a light thread, and if it doesn't go straight through really quickly, really easily, or you're any doubt, they need to be referred on, because although they are benign, they are quite destructive. So they need to be given a surgical opinion to discuss, what should or shouldn't be done about them.
But the vast majority of ganglions, certainly the ones that you see, they present a lot in younger people. They're often, come and go, so they can be quite big and then they disappear. They're generally asymptomatic. And I think our aim, I see quite a lot coming through my triage clinics, particularly because people don't like the cosmesis of it, is just to reassure them. A lot of them go away, they just disappear and never come back. We have a pretty, again, very much, even with surgery, there's a good 10% chance that you get recurrence of a ganglion, even with surgery. And surgery is not that easy. You have to get right down to the base of the ganglion stump, and that can, cause scarring and problems, particularly in the wrist. So I think it's very symptom related, and so long as you've excluded, and I think if you're worried about it, imaging is always going to be the best way to assess. You can also, things like, they will develop very slowly. You can watch and wait and see how things develop. Heberden's nodes, well, I would say Heberden's nodes are, very much related. DIP joint, osteoarthritis, wear and tear. They can be very uncomfortable. They're certainly quite unsightly. But they're generally something that settles down, so they're often painful initially but settle with time. And they can be something that are fairly easily managed from a therapy point of view with just some support, some Coban wrap, a little neoprene tube, a digi-sleeve out of lycra, something that just gives a little bit of support, a bit like a shin pad, just helps to give a little bit of shock absorption. But they're not something, again, that needs much management other than symptom related.
Brilliant. That leads us nicely onto treatments, really, I suppose. So, yeah, I mean, we mentioned splints and things before. deepest, darkest Facebook, I've seen people write things like, hands are only really treatable with surgery and injections, but obviously I doubt that's the belief in the room here today.
Not really, no.
But what we obviously said we need a blend of OT and physiotherapy type skills. What would you say, if we're starting to manage these hand types? Obviously we're going to look at general health and those systemic type things that we talked about earlier, but what kind of things would you go for? What kind of treatments are you looking at?
For anything in particular?
Well, let's say we'll start with the sort of the work-related disorders. The overload type syndromes, dequervins, etc. Where would you sort of start with those kind of conditions?
I think one of the big things with these is dequervins is one of those topics that you probably need a whole podcast on.
Yeah.
It's something that is, dequervins tenovaginitis as a condition is heavily overdiagnosed. I think what an awful lot of people get post having a baby, certainly as an overuse, is a tenosynovitis of those two tendons, APL and EPB, in the first dorsal compartment. And it's often an acute inflammation that occurs following an activity or following an overuse for a very repetitive activity. And it should be treated as a tenosynovitis. Again, very much as if it's acute, rest it, ice it, do some eccentric and gradually come, set back in with activity modification. A true dequervins relates to a mechanical change within the first dorsal compartment, and that may have an element of inflammation to it, secondary to that, but I think it's often something that needs different management and may need to go on to have other treatments that are not hand therapy related. So some comes back to the symptoms that you see. Splints very much for rest. If you have an acute, painful, maybe trauma, you need to rest it. And as we said earlier, some off-the-shelf splints are fine, but a lot of them don't fit well, particularly when you start looking at the thumb. It's relatively okay to find an off-the-shelf wrist splint. It's almost impossible to find an off-the-shelf thumb splint that fits really easily.
And doesn't apply pressure over the radial styloid. Which nearly all of them have a strap which goes around the radial styloid, and if someone's really sore and painful and acutely tender to touch, but they have to carry on working, and you want to have them in a position where they can work whilst wearing their splint, they need to have a splint that isn't pressing on their radial styloid. So actually, bespoke splinting is often the only way to go, really, to give these patients some comfort and relief and a position to rest in whilst as an adjunct to all your other treatments. But splinting, I think perhaps sometimes hand therapists are seen as just splint and let them get on with it, rather than we see splinting very much as just one of the other tools on our toolbox. But splinting for the dequervins, I think it has to be bespoke, really. I don't think I've ever found one that
works well. And I think also the one of the reasons for splinting, I think we need to be careful. There's a tendency with a lot of hand conditions that you put someone in a splint for 4 weeks or 6 weeks and then you take them out and get them moving. Actually, it needs to be done in a different way. Long-term splinting, even for as long as 6 weeks, is really poor for stability. We know, like the low back, that actually those core muscles start to become weaker very quickly, and a period of immobilization around a wrist and thumb in particular is causes quite a lot of issues. If someone's going to be in a splint, it's very important, I think, for them to be doing some isometric exercise in the splint that doesn't irritate. They need to be taking it off if they can, to do some gentle eccentric, within a limited range, something that's going to maintain both the sort of brain's memory of the muscle, but also just keeping it in good condition while we're waiting, and then changing your splinting as soon as you can from a thermoplastic solid splint to something that maybe is neoprene, that's a step down, that allows some support. Maybe at that time use taping as well, so that you're giving good proprioception, you're giving some support, but you're not stopping the muscles from doing their work. And it may be they need some sort of support for months, but none of it's going to work unless you're doing activity modification. You're looking at their grip. So a lot of the problem, again, when you have pain around the radial side of the wrist, is the type of grip they use and the position that their thumb sits in when they're gripping and holding the position of their wrist. So there has to be quite a lot of work done on activity modification, environment, what they're doing with their hands during the day.
I find there are, one or two kind of key exercises that I find really helpful for these. So when you're trying to get the stabilising muscles around the first CMC of the thenar eminence to sort of work again, because it's no different from any other joint. The muscles surrounding the joint just, they just switch off when there's been a lot of pain. And simple exercises like starting with thin piece of paper, showing the patient how to hold the edge of the paper between the finger and the tip of the thumb, either with just the index finger or with the tripod grip with the index and middle finger, keeping the paper steady and just tearing the edge of the paper with the other hand, the whole time keeping that thumb in that good position. And you will find big, strong people who can't do that. They can't just simply tear the edge of the paper without their thumb twisting around into all sorts of horrible positions, because they've lost that ability to stabilise that sort of pillar. And then obviously with something like that, it's really easy to progress. You just add another bit of paper and then another bit of paper until you can tear lots of bit of paper. But I emphasise that that's the side that's keeping the paper steady while you tear with the other side. So that's a really simple, really nice way to get good isometric training really early on. And obviously you want to say to patients, it doesn't matter if it hurts a little bit when you do that, but obviously you don't want to stir it up so that it's really painful, for another half an hour, 40 minutes later they're cursing you. So exercises like that, whilst they're being splintered, really important, because you don't want them to just come out their splint and have nothing.
And I think looking at, it's easy in the hand to go straight for strength. So it's easy to think you need to get straight into TheraBand, you need to get straight into squeezing a ball. Actually, we need to think about it like we do all the other muscles, that you have to start slowly and build up. And if you've lost any conditioning, you need to build that in quite slowly. And I think if you're doing those exercises, you need to take that into function. So we're always looking at trying to get people to grip things with that thumb and finger being in an O shape. And they need to do that when they're gripping and holding in function, because if they use an adduction position, if they go back to using their phone in that adducted position the whole of the rest of the day, they're going to get pain again. So you've got to get them to take those exercises then into function. So get them doing some activity within it. And if you do an activity like tearing a piece of paper, rolling a ping pong ball, things that are taking you into a more functional grip, that will again lead them into doing it better in function.
And how about these patients who sort of have these sort of problems with work related? So they're doing a lot of maybe static gripping at work or something similar to that. Would you still use the same sort of approach in training those muscles? And if so, how do you then, it's the same problem with people who walk a lot and you say you need more exercise. Have you got any sort of tips on how you get around that sort of scenario with people sort of adhering to those exercise programs, that sort of thing?
Well, I think you need to make sure that you've looked at the rest of the limb in those patients really specifically, because if they are deconditioned or just not particularly strong, shoulder, elbow, prosupination, and they're expecting that hand to take all the weight. I can't remember the last time I gave someone hand exercises and didn't give them something like an Arnold press as well. And we'll always do that, because you've got to make sure that, and quite often you'll find that actually people have just got atrocious strength and stability. They can't do an Arnold press with a 1 kilo kettlebell. So I always give them an upside down kettlebell, because that really helps with the wrist stability, because you've got to stop it clonking you on the head on the way back down again. And people can't do it. Strong, young people who think that they're perfectly fit can't do it without it clonking them on the head. So something like that as an adjunct. And I think that is something that often can't be ignored. When you're looking at these very small muscles of the hand.
Sorry, guys.
That's all right. We'll cut this
So
out.
that's all right. We'll cut the
We'll cut you out.
One more bag to go.
One more bad. I've completely lost my train of thought.
Upside
was
down
I saying?
kettlebells.
Oh yes, I was saying. What were we talking about?
That you can't ignore doing
Can't
that
ignore
sort of
it.
thing.
Yeah,
as,
so
as
so
well
you've
as
got
the
someone
hand.
that's using their hand all the time, and they can't think why they're getting these problems because their hands are really strong. Then you have to look at the rest of the limb, because as Sarah alluded to earlier, when you don't have good stability proximally, you don't have good stability distally. And it's amazing how often these people have really poor stability proximally, and you just wonder if it's a chicken egg thing, isn't it? What came first.
And I think it's, we do quite, I think you've got to look at people being at work. We know there's a lot of negativity about people being off work, and I think it's very, very important to try and keep all of these patients at work, because there are all sorts of financial and psychological issues, as well as further deconditioning if they're not at work. But I think you have to spend a certain amount of time just looking again at phased returns, looking at specifically breaking down the type of work that they do, what are the safe grips, what are the safe parts of their jobs to do. And we fill out a lot of the AHP fitness to work forms, where again you as a therapist can make recommendations to the employer as to what are the safe things. And sometimes it's literally just as simple as the patient being given permission to stop every 20 minutes to do some refresh exercise. Patients are often, we treat a lot of sonographers who really struggle with hand pain due to the position their hand has to be in holding the ultrasound probe. And often they haven't even considered that if they just move their body, their wrist doesn't need to be in lots of flexion, because they're all taught to sit in certain positions. And so we'll get someone to take photos of them at work in their normal positions, and then do quite a lot of work on getting them to work out. And again, if you can get them to take ownership, they will follow it through much better. What can they think to try and improve the position? So you need to do the local exercises for conditioning, just as you would for low back pain or an unstable ankle or an unstable knee, any of those. But alongside of that, they've got to put that into work. So I think keeping at work, but doing it in a way that makes it possible. And if need be, getting them to understand that there are some things they may need to avoid and never do in that way again. They have to change some aspects. And then some things they can do just as they want to. So it's got to be part of that holistic return to work or staying at work, but in a way that makes it manageable. And not only work. I think it's easy for us to focus on what happens at work. You've got to look at their life at home, because it may be that what they're doing at home is just as much of an irritant to their pain than what they do in their work role.
Yeah, very good. And what about sort of the entrapment? So carpal tunnel, for example. Obviously, we talked about splinting a little bit. Is there anything more active that people can do to help with carpal tunnel, or do you work on coordination type exercises or anything like that to go along with the splinting?
Yes, I mean, it does depend how bad their carpal tunnel is, and whether it's come on really slowly, whether it's come on with a bang, because obviously their presentation is, quite variable. The carpal tunnel, as I'm sure everyone who listens to this knows, has got quite a lot of stuff in it. Okay, quite a few tendons, and the tendons and the nerve all need to be able to slide and glide really fluidly. You've got to think about your spaghetti that you've made, and it's really got nice olive oil on, and it's all slipping and sliding around, compared to the spaghetti when we forgot to stir it in the bottom, and it's all kind of stuck in the bottom of the pot. And if you have had any inflammation, or you've had an injury, or you've had compression, or even post-surgery, if they've had a lipoma or something removed, you've got to make sure that all that sliding and gliding is going on. So in terms of specific exercises for something like carpal tunnel, individual tendon gliding is a kind of a go-to exercise for most. Obviously, you can't give every exercise to every patient, but as a general guide, so making sure that you're performing individual gliding of all of FDS, all of FDP, and not to forget FPL. Really important. And then everything is moving, and then with that doing your median nerve glide, so either just at the wrist or as part of an upper limb well, I don't know what they call it nowadays, upper limb tension test 1, that type of movement, median nerve flossing, whatever the terminology you want to use, but getting that gliding and movement of that nerve. I mean, we know the nerve doesn't stretch. We know that the nerve has to be able to glide through that tunnel. You've got to make sure it can do that. Tendon gliding en masse. So you can do all of FDS together and all of FDP together, or possibly both. I don't know what you normally do.
Yeah, no, I would agree with that completely. I think the one thing to avoid sometimes is that we know that there are a group of patients whose carpal tunnel becomes irritated by the origin of their lumbricals. So the origin of the lumbricals is normally just distal to the carpal tunnel, but in some patients it sits a bit more proximal. And so when you make a fist, those lumbricals will intrude into the distal part of the carpal tunnel and can cause a lot of irritation. So one of the things when you're looking for exercise is just to test and see if you get someone to make a really strong fist and sustain it. If that produces any change in their symptoms, then you know they're one of those patients where the lumbricals are an irritant. So you need to avoid sustained end range of grip because that is a specific irritant to it. So I think the tendon glides, as Deb said, are by far the best way to do it, but be a little bit careful about strongly squeezing a ball, until things have settled down, because you may find that's one of the things that continues to cause a nerve compression. And I think thinking just about keeping the wrist and everything gliding and moving. Rested at night. If you're resting it at night or resting it for periods of time, it must be rested in neutral. So all the off-the-shelf splints that are given have the metal bar in all of the splints at 30-35 degrees of extension. That is an irritant. So that increases the pressure within the carpal tunnel by quite a high percentage. So if you're going to be giving somebody a splint to wear at night, which is definitely a sensible way to start, you must flatten the bar in order to maintain it in neutral.
And you mentioned about sort of refresh type exercises. We said about roughly every 20 minutes or so for someone who's got a relatively static job. Would that be the sort of period of time you'd be looking at?
I think there are very few people. I don't think that's realistic. I think that's sometimes we say that to people to try and make them think about it often. I think depending on what you are doing, if it's very static, if you're at a computer, a graphic designer, someone who is literally in that position, you probably want them to move a bit more often. Most people 1 to 2 hourly. We think Debs is reasonable. It's good to set a reminder. We all get involved in what we're doing. But the more static in your history you'll work out from your patient as to the postures they're in, the more static they are, the more you need to make sure they just change and move. And it's about how irritable things are. Some people can use a mouse for 2 or 3 hours and they have no problem at all. Other people start getting some symptoms within 10-15 minutes. So you need to relate your refresh to their symptoms. And a lot of the refresh are quite global. So often the best refresh are the ones just like doing breaststroke that actually gives a bit of neural glide, that you can't do breaststroke unless you sit yourself up straight, because otherwise you're going to hit the table. So actually just the fact of sitting upright, moving your arms in a couple of breaststroke positions is going to get some neural gliding, change your trunk position, etc. So you can do some very simple, quick movements as well as some specific that you may need to give for whatever the patient is experiencing. But I think it's and they need to do it at home. They need to do it if they're on the sofa watching the television for a couple of hours. They need to do it then as well. If they've got an hour's train journey and they're going to be sitting on their phone, with a lot of neck flexion, thoracic spine flexion, elbow flexion, etc., they need to do it in that hour that they're on the train. Not necessarily breaststroke, but they need to do something to keep everything moving.
Brilliant.
Yeah, I would normally do exactly the same. I quite often ask them to do the put your hair up as well. So breaststroke moves, and then imagine you've got long hair and you're bringing it back into a ponytail just to try and get that other aspect.
And ideally, I guess, a thoracic rotation. So a little bit of, imagine someone's come up behind you and you need to check who they are and just do a quick, just move your thoracic spine. They seem to be the areas that are most irritable to do, and none of us, do that regularly enough.
No, there are lots of programs now that people can put on their computer. I mean, the best ones just make the screen go blank for 30 seconds, which might be quite annoying if you were doing something really important, but they don't affect what's going on in the background. But as we know, often the severity of these types of symptoms is closely related to how much pressure is being put on people to complete their tasks within whatever period of time. And of course, those are the people that don't feel that they've got time to stop and do their refresh exercises. So giving them something exactly as Sarah said, that they don't have to get up, they don't have to move away from their desk, they just have to sit up, lean back, do 2 or 3 big breaststroke activities, will not add to their stress and anxiety of getting things done. Though of course that is something that has to be addressed separately.
Yeah. And I think that's we've said about just the holistic is just ask them about their environment. Ask about, if you're in an office with lots of other people, there will be other people without a doubt that have some upper limb discomfort. And so, get everyone to do it. Talk to the managers, can everyone just have that? If everyone, one person stands up and everyone does it. Because it's in countries like Japan, Taiwan, etc., where they have a mandatory bit of physical exercise regularly through the day. They have to get up and do star jumps. They have to get up and do something. They don't have the same level of work-related upper limb disorder that we do. So a lot of it for us is, get it done in a way that makes everyone do it. You don't want people to stand out. Somebody won't stand up in a busy office and do something that makes them look silly.
Yeah.
But everyone needs to do it. So talk to them about, can everyone do it? Where do they go for their lunch break? Can they go, can they just walk to the second coffee shop? If they have coffee at their desk, can they do something that means they're moving on their way to get coffee? Just to try and incorporate it in the easiest way possible.
Yeah, brilliant. Well, I've learnt tons. I'm not bothered about the rest of the listeners. I've learnt loads about hands. Is there anything, Sarah? We can start with you if you like. You've obviously mentioned your courses and kind of things. Is there anything you want to point listeners to for yourself, or courses that you might recommend, etc.? If someone listens to this and they go, "I want to be a hand therapist,"
I think there to go from being either a more generalist OT or an MSK physio to being a full-blown hand therapist is a lot. For us to reckon that you can be an accredited hand therapist takes a minimum of 5 years to get the basic skills to train as an OT and a physio to get those skills. I think you can, a lot of it in the first instance is about assessing, is understanding the different conditions, looking at differential diagnosis, looking and understanding when it's appropriate to refer on, as we all do. That's one of the things everyone needs to do. There are courses out there on differential diagnosis. We're going to the website for our training is NES at neshands.co.uk. We're just about to start some online courses, so the first 3 should be uploaded by the end of March. So the first ones we're doing on hand and wrist goniometry, so they incorporate the skills as to how to do that. There's going to be one on PIP joint anatomy and biomechanics, and one on assessing the wrist, so looking at provocative testing and differential diagnosis. So they'll be on our website. Keep an eye out on Facebook and Twitter.
Yeah, we can link to all of these things
for those. And then look, if you really do want to be a hand therapist, you need to get a job working in hand therapy. BART, the British Association of Hand Therapists, does accredited courses at different levels that bring you in. You can now, they've recently changed the way things happen. You can come as an MSK physio. You can now attend some of the level 1 courses to gain the skills, and in some situations the level 2, which is more specific, like the wrist, assessment of the hand, the PIP joint, things like that. There are acquired conditions. There are now courses where BART is happy for MSK physios to attend those, so long as a good proportion of their work relates to the upper limb and the hand. So there, I think it's very important to learn the skills and understand that hand therapy is about being holistic. It's about understanding the sensory side, the splinting, the exercise, etc. So you need all of those.
Yeah, brilliant. Anything you want to add to that, Debs?
I don't do any external teaching, so I haven't particularly anything to plug, but I will say that I think that the NES courses are absolutely worth their weight in gold. So I think that if any of my staff come and say, where should I go, where should I start, then they're definitely where I point them to, because I think that's where you get not only the best information, but you it might put people off, but there's a pretty tough exam at the end, and there's also a 6-week case study, so that you are examined and assessed on what you've learned. And although that's scary, that's very reassuring.
And I guess the last thing, just as a final plug from our point of view, is just quite a lot of people won't be able to do the BARD courses, which are 3 days, but we also run a lot of bespoke courses. So, we may just do an afternoon for a team or a day, or we're going up to Dundee to run a 2-day course on rheumatology for their team. So, look on our website. We're happy to set up any course for any department or group of departments that would like specific training and teaching. So look on our website, all the details are there.
Actually, there was one other thing that would be worth mentioning, and that is people that see have rheumatology departments that refer their hands. Anybody out there that's treating those patients that hasn't come across the iSarah program, that is absolutely definitely worth doing. So if you just Google, or whatever your preferred browser is, iSarah, so small I, capital S. It's a program that has been developed at the University of Oxford, and it's a program which comes on the back of a long study, and it's stretching and strengthening for rheumatoid arthritis in the hand. And you can do an online course. It's supported by videos, and there's lots of stuff you can print out to give your patients. There's an assessment at the end, and it's a really excellent starter for someone who might be seeing their first kind of rheumatoid hand patients.
Brilliant. That's great. Well, I've got to thank both of you. Thanks, Debs, for putting us up in your kitchen to to record the podcast. We've had the dog and the coffee machine. Hopefully it doesn't come through too much on the recording. But thank you very much for your time today. I think the listeners will find it invaluable. I certainly have. And hopefully we can all be a little bit more confident with hands, and at least assessing them and sending them on, giving them a bit of treatment, and managing them a little bit better, hopefully. So
Great.
Thank you.
Thank you very much.
Thank you.
Right, thanks.
Well, there we have it. Thank you very much for listening to Debs and Sarah. Thank you to them for giving up their time generously, as all our guests do. One thing I would sort of take from this podcast is, as many of our guests have previously, we need to be listening to our patients' stories. They can tell us their diagnoses, tell us what their issues are, and really they tell us what we need to do to help them. The hand is an extremely complex area. Something that I feel like is a weakness of my clinical skill set. I think it's very important to be thinking of structures outside of the localized area, as pointed out, the C-spine and potential masqueraders into the upper limb. Even so, we're still looking at those neurological type or symptoms, as well as referred pain from the C-spine. I think very important to clear those before we decide definitely it's an issue with our hand. And then, as Debs and Sarah mentioned, I think knowing our skill set and knowing our scope of practice, referring onwards to specialist hand therapists as is necessary. Once again, I'll just remind you, please head over to our Kickstarter campaign. Donate us anything that you feel appropriate and help us to bring you more better content in 2019. We've got brilliant podcasts planned for the next few, real clinically applicable sessions that I think will be super fascinating and really help us in clinic as usual. Don't forget to check us out on social media. We're at TPM Podcast on Twitter, Physio Matters Podcast on Facebook, Instagram. You can follow myself for any of your rheumatology requirements at PhysioJack. Please get in touch with us with any feedback, comments, questions. We're always happy to engage. The Twitter account's getting quite heavy now. You're just as well off sending us a direct message as you are tweeting us, because things can get a little bit lost in the feed with all the notifications that come through. So if I don't reply to you on Twitter, I apologize. It's just got lost in all the other notifications that come up on there, and we really like getting in touch. You can get directly in touch with us by email inquiries@choosehealth.co.uk, when we will endeavour to answer those emails as well. We always like to hear from you, and until next month, I will leave you with the cheesy sign out. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.